Hello friends, today I'm going to discuss a very common complication in early pregnancy, which is early pregnancy bleeding. Okay, and whenever there is early pregnancy bleeding, that is bleeding in the first trimester of pregnancy, we think of mainly three conditions. We think of abortions, we think of ectopic pregnancy and molar pregnancy. Now today I will focus on abortions. Now when we talk about abortions, please remember that there are various kinds of abortion, like spontaneous abortion, like induced abortions or recurrent abortions, right? Now as the name suggests, spontaneous abortions are something that happen on their own, okay, and majority of these spontaneous abortions are confined to the first trimester itself, and that is what we are going to discuss today. So friends, let us look at the first clinical scenario. There's a 25-year-old nulliparous woman who walks into the OPD with 1.5 month period of amenorrhea, okay, and she has bleeding. Actually, there's just slight spotting for the past 2 hours. She does not complain of any pain, so there is no pain. She has done a home-based pregnancy test, and we know that she is pregnant because the urine pregnancy test must be positive. And on pelvic examination, the uterus is found to be about 6 weeks in size and the os is closed. So how do you proceed? Now before we move on to how do we proceed, let us consider the differential diagnosis in this situation. Now the first differential diagnosis in this situation is of course abortion. Okay, abortion is a clinical term which in layman terms we call as miscarriage, when the pregnancy fails to carry, that is miscarriage. Okay, and what happens is the woman complains of predominantly bleeding, which is then followed by a period of pain. So more likely it fits into the description of abortion. Had there been pain as the predominant complaint, okay, so pain followed by maybe a little amount of bleeding would go more in favor of the differential diagnosis of an ectopic pregnancy. So the second differential diagnosis is an ectopic pregnancy. Now why in this situation is it more likely an abortion? Because of our clinical examination. So very important, apart from the history of the symptoms, the chronology of events, another important feature is that the uterus is about 6 weeks in size. Now in ectopic pregnancy, when the location of the pregnancy is outside of the uterus, all right, most commonly in the fallopian tubes, then the uterus would not be enlarged, right? So that more so goes in favor of our diagnosis, which is abortion. So how do we proceed? Basically, the first and foremost important thing that you should be doing is actually confirm the period of gestation, because that is our basis. We are going to correlate the period of gestation with the size of the uterus. Okay, so basically you all have to confirm the period of gestation first. So ask her the LMP according to the last menstrual period, the date of the last menstrual period. Calculate how many weeks into pregnancy she is. And now what is the likely diagnosis? So the likely diagnosis so far is abortion, okay, and we have to proceed by confirming the period of gestation. And secondly, now the main concern is how is the pregnancy doing inside, right? So to establish whether the pregnancy is doing well or no, one has to move on with the ultrasound. Now before moving on to the actual report of the ultrasound, let us see what is happening here. Okay, so the woman is complaining of bleeding per vaginum, okay, bleeding PV, BPV, and apart from that she probably has just mild pain or maybe no pain at all. And we can see in this diagrammatic representation that the baby is still inside, and what is happening is that there is bleeding behind the chorion, behind where the placenta should be. So this is something that is called as subchorionic hemorrhage, subchorionic bleeding or subchorionic hemorrhage, right? So what this hemorrhage is going to do, or has the tendency to do, is that if it increases in amount, it can completely just dispel this developing embryo inside, right, and lead to increasing amounts of bleeding, leading to painful uterine contractions in an effort to expel the contents. So that is the cause of the pain that happens with abortion, right? Now, another important point in examination in this case was the fact that she had a period of amenorrhea of 1.5 months, right? So approximately, let's say that she's somewhere around 6 or 7 weeks pregnant, right? And the uterus size was also 6 weeks. So what we saw was that the period of gestation was corresponding with the uterus size. And very importantly, as we can see here, the os is closed. So when this is the clinical situation, right, then the likely diagnosis is that she is in a state of threatened abortion. The threat to abortion is very real, okay? But what is the important point is that the os is closed. So the process of actual expulsion has not started. So this is what we call as threatened abortion, okay? So moving on, like we saw in the pathology of abortion, the same is reflected in the ultrasound report. So the transvaginal sonography shows an intrauterine gestational sac. So we can see an intrauterine gestational sac. There is an embryo inside, right? The crown rump length is about 5 mm. The cardiac activity is present. Now, so this is a diagram, right? Or this is a photo. So the cardiac activity I cannot show you until unless, of course, it's a Doppler. But let's say that the cardiac activity is present, but there is a small subchorionic hemorrhage right here. So the diagnosis of threatened abortion is yes, in fact, confirmed. Okay, so how is the woman managed now? So basically, of course, she has to be counseled. Okay, so counseled and told actually what is happening. So that is a very, very important point. Okay, the other thing is conservative management. Conservative management is what that is followed. So what is this conservative management? It includes rest. Okay, now rest does not mean just actual bed rest. She's not supposed to be bedridden, of course, right? What is advised in rest is that she is advised to avoid excessive exertions. She's asked to avoid intercourse, right? Heavy weight lifting, or climbing up the stairs too often. So basically a little restriction of physical activity, and that is all that is required. Okay, now apart from that, is there any role of progesterone supplementation, right? So I will mark it as query because some people give it and some people don't. Basically, there is no evidence behind giving progesterone support in these clinical situations. Why? Why? Because most of these cases of spontaneous first trimester abortions are actually chance events. What I mean by chance events is that most commonly it is the fetus that is at problem. It is the fetus that is chromosomally malformed. Okay, so there is nothing actually wrong with the progesterone support to the pregnancy, right? It is because the fetus is chromosomally abnormal that it is not surviving in utero. And that is the reason why this progesterone support is quite controversial. Some people do give it to give the woman a benefit of doubt. Some people do not give it. So it's either way is okay. But what is important is rest. Okay, so this is how a threatened abortion is managed. So moving forward, let's tweak the clinical scenario a little bit. A woman in threatened abortion could just simply be okay. All right, the bleeding could stop, the pain should no longer be there, and the pregnancy continues well and good. But the other situation is that the bleeding increases, the pain increases, right? So look at what happens here is that the size of the subchorionic bleeding significantly increases, like I told you. That increases the amount of bleeding, right? That causes a lot of pain because now the uterus is contracting in an attempt to expel these contents. So there is a lot of pain. Okay, so moving on. As we can see here, there's a 25-year-old woman, again the same situation, 1.5 month amenorrhea, bleeding is mild for 2 hours. Now she has cramping abdominal pain as well. The uterus is 6 weeks. What is different here? Remember friends, is that the os is open. So yes, the period of amenorrhea or the period of gestation does correspond with the uterus size, but the os is open, meaning that the contents are all still inside, only that the os is open. And once the os is open, that means the woman has now entered into a phase that is called as inevitable abortion. Now there is no stopping this. That is what is meant by inevitable. Okay, and how do you manage? Now, management, apart from managing this clinical condition, understand that the woman is bleeding, she has pain. So all those factors needs to be taken into consideration as well. So ideally, one should definitely go for a blood group testing, right? And ABO testing. Remember that Rh negative women, right, who tend to go into spontaneous abortions, they also require anti-D injections. Okay, so that is why blood grouping, ABO typing, a measurement of the hemoglobin status of the woman, whether she is anemic pre-existently or no, that is very, very important, right? Now, for the inevitable abortion bit, we let it progress. Okay, so we do not unnecessarily intervene, put in instruments inside the uterus and try to just, hasten the expulsion unless it is required. So very importantly, she might just have a spontaneous, uneventful abortion on her own, right? So we let the situation progress and we intervene only and only if the bleeding becomes very severe, if the woman decompensates because of that increased amount of bleeding. Only then do we intervene, otherwise we let it progress. So moving on, let's tweak the clinical scenario a little bit further. Let's say that I see this woman after she has bled at home for a considerable duration of time, or she has had a significant amount of bleeding already. Okay, so what has happened here is the natural process of expulsion has taken its course, and as we can see in the diagram, what has happened is that the products have been expelled and some of the products are on their way, right? So on their way to expulsion, the os is open. Another very important point will be that because the part of the products have already come out, the size of the uterus, right? The size of the uterus is going to decrease. That is what is going to happen, and the bleeding, of course, is going to be much more in this clinical situation. So as we can see here, again, she's the same woman right now with 3-month amenorrhea, let's say, bleeding for 2 hours. Now, very importantly, whenever a woman complains of bleeding, one needs to know how much bleeding, right? So that is the question that we ask, and we can ask her, is she passing clots? Is how many pads she has soaked? So this gives us an idea about the amount of bleeding. Okay, so she's soaked 3 pads fully in 2 hours. That is quite a lot. There is cramping, lower abdominal pain. The uterus is 6 weeks in size. So look at the period of amenorrhea here. 3 months. If I were to calculate it based on LMP, let's say for example she is 12 weeks. According to her LMP, let's say she's probably 12 weeks pregnant, but the uterus the size of the uterus is less, right? And the os is open, right? So what is the clinical diagnosis right now? The clinical diagnosis is what we call as incomplete abortion. Okay, Now, in this clinical situation, how do we proceed? Okay, how do we proceed? So again, estimation of blood grouping, ABO typing, right? Hemoglobin estimation. Apart from all of that, I of course want to perform an ultrasound as well right now, right? So let us say we went ahead and did an ultrasound. So on ultrasound, as you can see here, the transvaginal sonography shows that the uterus is bulky in size. There is an irregular endometrial stripe. As we can see here, the endometrial stripes looks irregular, and what is important is that there's this hyperechoic contents inside the endometrial cavity, okay, measuring about 2 to 3 centimeters. Likely they are retained products of conception, okay. So that means some of the products are still left inside. It is incomplete abortion. The diagnosis is confirmed. So how do you manage now further? Of course, we manage now by completing the process, okay, by completing the process. So what we can do is we have to evacuate the RPOCs. What are RPOCs? Retained products of conception. To evacuate them, we can use any of the surgical methods that are handy, that are available to us at that point in time. It could be putting a suction catheter inside and then sucking out the contents. That is called as suction and evacuation, SNE, right? If we don't have a suction apparatus with us, we could simply use curettage, okay? The os is already open, so I will not say dilatation, right? But nonetheless, maybe dilatation is required depending upon how much of the os is open, all right? So dilatation and curettage can also be attempted, and removing these products will then significantly stop the bleeding. Okay, so that is how this condition is managed. Now let's look at another clinical situation, another scenario here. The same woman walking into the OPD with 2 months amenorrhea, all right. Bleeding PV has been there for 4 hours. Cramping pain was also there. She has soaked 3 to 4 pads fully, but very, very important, another important point in history that should be always asked, apart from the amount of bleeding, apart from the pain, is that how is your bleeding right now? How do you feel is your bleeding right now? So this woman says that her bleeding and pain has subsided, okay. On examination, the uterus is bulky, so she is 2-month period of amenorrhea, so somewhere between around 6 to 8 weeks maybe, okay, but the uterus is not corresponding in size, so the size of the uterus is decreased as compared to the period of gestation. Os here is closed, okay, so that is the differential point here, that the os is closed and there is no active bleeding. So of course, what do I want to do next? I want to see if there is something still left inside the uterine cavity or has everything emptied. So I go for an ultrasound. The uterus is bulky. There's a thick endometrial stripe. Very importantly, the cavity is empty. And now the likely diagnosis is that she has had a complete spontaneous abortion on her own. So complete spontaneous abortion. How do we proceed? Do we need to do anything else? Nothing specific needs to be done. Nothing specific needs to be done. Okay. So for her current condition, right? Nothing needs to be done. But that doesn't mean that we just let the woman go. So this is the time when she has to be, because see, this is the time that she has to be counseled about what has happened with her, what are the likely causes, and it has to be assured to her that this is probably a one-time event, because most of the causes are because of chromosomal abnormal fetuses, and that this situation is unlikely to repeat again. All right, so counseling, reassuring is what is done. Another important thing that needs to be done here is do a blood grouping and RH typing, because if she is RH negative, she will need anti-D injection. If she wants to conceive in the future, she should be advised regarding that. If she doesn't want to conceive, she should be advised about contraception. So just for the fact that, you know, she has to be let go regarding that it has a complete abortion doesn't really mean that no more counseling, no more assurances required. So moving on. The scenarios that we discussed so far were all OPD based scenarios. The woman had walked into the OPD. So if I say that somebody walks into the OPD, I assume that her vitals are definitely stable, okay, and she's not bled much. But let's just see another clinical scenario here where there is a 30-year-old multiparous woman, okay, so slight change there, is wheeled into the casualty with severe bleeding PV for the past 2 hours, right, and cramping lower abdominal pain. She is extremely pale. Now, when a woman gets wheeled into the casualty in the emergency department, action needs to be very quick. So you have to have a quick evaluation. Somebody who's bleeding needs to be evaluated, how significantly pale she is looking, right? The pulse rate is 110 per minute. The BP is 80 by 50 mmHg, so she has tachycardia, she has low BP, means she has lost significant amount of blood, she's going into shock. How do you proceed now? So now friends, since you have to act fast, all right, your activities will not be like you're sitting in the OPD. You have to take a quick history, you have to perform a quick examination, and of course you have to start resuscitation simultaneously. Those things have to be done together, right? So you begin immediate resuscitation, send the immediate investigation. Now the investigations are the same: blood grouping, RH typing, hemoglobin estimation, all right, arrange for blood. She's significantly pale, she's losing blood, she might need blood transfusion, so arranging for blood, calling up the blood bank, all these are measures which have to be taken immediately, right? Apart from that, let's see what a quick history tells us. We took a quick history and there is history of preceding amenorrhea for 3 months. So that is something which was not given in the initial clinical examination, right? Or the initial presentation. They just said that she had come with a lot of bleeding. What is very, very important to understand, any woman in reproductive age group, all right, when comes with an acute episode of bleeding, always and always rule out pregnancy complications, okay? Even though she denies sexual intercourse, even though she denies, any period of amenorrhea, very, very important, always consider pregnancy-related complications or abortions as a differential, all right? So here in this case, there is a history of preceding amenorrhea, all right? There is also history of MTP pill intake, so she has inadvertently, or let's say somebody has given her over the counter, or she by herself or by some quack has managed to take these MTP pills, all right? On examination, the abdomen is soft. Her undergarments are completely soaked with blood, all this signifying that there is a lot of bleeding that is happening. Now friends, remember, in all the previous case scenarios, we went ahead with ultrasound, okay, because ultrasound is so widely available. There is a documented record, a report that comes, and woman can see for herself what is happening in the report and so on and so forth. But this is one condition when I will do away with an ultrasound, where there is importance of clinical examination or per-vaginal examination. Very, very important. The woman is in shock, right? And I don't want to subject her to an unnecessary ultrasound when the diagnosis can itself be made by just doing a clinical examination. A simple per-vaginal examination revealed that the uterus is 6 weeks in size, right? So 3 months. That is about 12 weeks period of amenorrhea, and on top of that the uterus is 6 weeks, so the size of the uterus is much less, the os is open, and the products of conception can be felt in the vagina, right? So now I don't need any ultrasound to confirm the diagnosis when the clinical examination is itself pretty evident, right? So do not skip clinical examinations, do not skip per-vaginal examinations when evaluating women in these clinical scenarios especially. So what is the diagnosis now? This is again an incomplete abortion, right? But yes, The bleeding is very significant. The woman is in shock. So how do we have to manage? The management is resuscitation, right? Do not forget resuscitation that goes on simultaneously, and evacuation. Resuscitation and evacuation of the period of of the products of conception, right? So the moment you are going to empty her uterus, it is going to contract, and that is what is going to stop the bleeding. So that is what is important. So friends, this is a brief overview of the various clinical presentations of abortions. Now, whether the abortion happens in the first trimester or it happens in the second trimester, the clinical presentation evolves through the stages that we have just discussed. Another clinical presentation of an abortion is a missed abortion or early pregnancy loss, which we are going to discuss in the next video. Thank you.